Welcome back to this month's Ask Me Anything. I am so happy to be with you guys here live today. Welcome. Thank you for some of the questions that have already been submitted. If you have questions, put them in the chat, or there is also a link for anonymous questions if you prefer to submit them that way in the chat for you as well. So I'm going to dive right in and get started. First question is from an anonymous submission. Is atherectomy done every time before a stent is placed? Is there a nominal depth for clearing out the plaque to the arterial wall? I would imagine there is a benefit for the plaque debris to be removed or suctioned out. I would imagine there's a benefit for the plaque debris to be, that's a duplicate. Do you have a preference for which procedure you like to perform, or depends entirely on the angiogram result? Thanks, Doc. Thank you for the question. This is like many parts. So let's first talk about what atherectomy is. So we are talking about a buildup of stuff, right, on the inside of the artery that is narrowing it or even blocking it completely. And the process of atherectomy is, atheroma is the plaque itself, and ectomy means to take out. So in the process of atherectomy, there is essentially a drill bit or another tool that comes in and either shaves down the plaque or tries to grind it up and remove enough of it that we have a better channel in which we would then most commonly place a stent, which is a metal tube which may or may not have a wrapping around it, but the tube acts as a scaffold to help kind of open up and push the walls of the artery back outward to make more room for blood to flow. There are a number of different ways to manage the plaque buildup. Atherectomy is one, and they fall under a whole category of things we would call vessel preparation or plaque preparation. The really densely calcified plaque can also be kind of manipulated using ultrasound waves to crack it, kind of like safety glass, so that it expands more easily. That is called intravascular lithotripsy. So like if you've ever had a kidney stone that they went in to go dissolve, that's lithotripsy for a kidney stone. This is similar. It's kind of similar technology where sound waves are used to make small little microfractures in the calcium that's in the wall of the artery and in the plaque, so that it expands and can be much more flexible and moldable rather than this like big stiff boulder of a rock. So atherectomy is one option. Intravascular lithotripsy is another option. Some people will just stretch it open with a plain balloon angioplasty, or POBA was the abbreviation for that. In some vessels, that's a good enough situation. In other vessels, we have to put a stent. Depends a little bit on where we are and whether the plaque is really soft, whether it's densely calcified. But in general, especially if it is completely blocked or occluded, then doing something to open up more of a channel will usually allow for a stent to expand better and give a better angiographic result. So that means it looks better when we're done with the procedure. The next question is, does it last longer than any of the other techniques that might not make as pretty of a picture, but might still get the job done to improve blood flow? That gets a little bit trickier to suss out. And at the end of the day, right now in 2026, I would say, the people who really promote atherectomy can find you data that supports its use. People who support other techniques will find data that support their techniques. There's not a huge amount of like head-to-head trials and comparisons that allow us to really definitively answer this question. It becomes a lot of the art of vascular surgery. How do I assess the nature of the plaque that I'm dealing with? What is the size of the vessel? What are the risks of atherectomy? Because when you grind up that plaque, sometimes it can go downstream and cause an embolization phenomenon or block up some of the vessels downstream. And sometimes the device doesn't go super easily. Sometimes we're thinking that, it's not worth it for a moderate lesion if it's, because it costs a fair amount, right, to do an atherectomy. So all of these things kind of get bundled up in our brains, and every surgeon or every proceduralist who treats this disease process thinks about it a little bit differently for themselves and for their patients. So there are times where I will treat one lesion in the popliteal artery, which is behind the knee, with atherectomy before I put a stent in. There are other times where I will treat it with shockwave lithotripsy before I put a stent in. There are other times where I won't put a stent in there at all if I can help it, because behind the knee is kind of an awkward place to put a stent because it flexes and bends, and there's a lot of ongoing repetitive stress to a stent that goes back there. So it all just depends on how bad the problem is, what that plaque looks like, what my options are to treat it in that particular person at that particular time, and what the ongoing considerations will be. So it's a long way to say it depends. But thanks for the question. I hope that was interesting and a little bit of a deep dive into some of the like very procedural specific things that I do every day as a vascular surgeon. All right. Welcome, Lisa. Welcome, Donut Time. Paul Elkins. So good to have you guys here. Kujai, I am 39, athletic. Angiogram shows clear arteries, but 24 millimeters mercury pressure in the left ventricle, LP(a) at 235 nanomoles per liter. After Repatha, LDL cholesterol is down to 125. Would I be more aggressive on LDL? So again, the angiogram, is that a CT angiogram? Is that a invasive coronary angiogram? Was there only a radiologist read, or was there actually some AI overlay technology to really assess for larger amounts of plaque? All of those are kind of nuanced pieces of this question. I would say at large, the general recommendations for somebody with elevated LP(a) would be to get LDL-C, which right now, until the LP(a) drugs are shown to be safe and effective, which we are not sure of yet, right? They're not approved by the FDA yet. Right now, the best solution we have to mitigating that risk is to improve your metabolic health and to lower the ApoB even a little bit further than we might ordinarily for a primary prevention type of a scenario. So yeah, it depends on kind of what your options are for additional ApoB lowering and whether you tolerate that and how you feel about your risk. What is your family history? What are your other risk factors? Are we doing everything we can on those fronts? Because I do think there's a lot of evidence that says while ApoB is relevant, it's certainly not the only thing that's relevant for plaque progression, right? We have a study that's showing waist to hip ratio is actually an important factor in whether elevated LP(a) conferred a lot of additional risk. For those people who had normal waist to hip ratios in one study, I think it was MESA, we didn't see a huge amount of increased risk related to LP(a). So does that mean I wouldn't lower ApoB at all or even think about it? No, it just means let's understand the broader perspective here and see if we can come up with the best long-term risk mitigation strategy for that particular factor. Thank you for a great question. All right. Hi, Mark. Welcome. Tom Smith, you made it. Awesome. Thank you for coming all the way from Melbourne. That's really exciting. Nice. All right. Paul, yeah, you chimed in there to help Kuja. That's great. All right. Man GRTS. Would I expect finasteride, dutasteride to improve mitral valve behavior based on their ability to improve cardiac remodeling in cardiomyopathy models? Interesting. I am not actually super familiar with that literature. I would want to go look at that a little bit more. I have to say that post-finasteride syndrome, so finasteride is a drug that actually a lot of men take for androgen-related hair loss. And it has, some people get a lot of testosterone suppression and a lot of like sexual dysfunction related to that later in life or after several years of taking that drug. And I've seen it be pretty devastating for people. So I actually, if finasteride is being used as consideration for hair loss, I'm not as enthusiastic about it. Cardiomyopathy is a whole separate issue, right? So let's think about that. I would have to go look at those data and what those models look like. Are we talking about animal models? Do we have human data yet? That's a great question. I'm going to have to go check into that before I am going to render an opinion there. But thank you for bringing that up. I will try to remember to bring that back as a comment response maybe next week. Okay. All right. Donut, I see you. You're there. Yes. Hi from Lake Tahoe. Welcome, Tahoe Style. If you have questions, pop them into the question. Yeah, Paul, you're right. I mean, those two drugs, finasteride, dutasteride, are also sometimes used for BPH. Again, I think we have better agents for that now, but it's definitely something that is still there. All right, Kujay, more information on your question from earlier. You said you had an invasive angiogram. So the thing about an invasive angiogram when we're looking for plaque is that it's actually not very good at detecting early plaque. What it will detect is narrowing of the lumen, right? So the flow channel in which blood is actually going. But the earliest stages of plaque, the plaque actually remodels the artery outward. It doesn't narrow the flow channel early on. So when you just have an invasive angiogram, all you can see, because they use contrast dye, and the contrast makes the artery fill with something that we can see on an X-ray. So all you see is the flow channel, but you don't see whether there's any plaque that's starting to grow outward, and you won't see the earliest phases of plaque deposition in the artery wall. So I'm very heartened to hear that there's no significant narrowing and there's no big calcium deposits that they can see on an angiogram. But based on your age, it does not really mean to me that you don't have soft plaque forming or early evidence of atheroma or disease formation. At that point, I would consider maybe more advanced imaging technology to see about that. So that could be an ultrasound-based test like a CIMT, femoral ultrasound to see if there's thickening or plaque there, or coronary CT angiography, which will have some ability to detect the soft plaque that grows outward first before it narrows the lumen of the artery. At Tech ADSR, would I look into Dr. Anthony J's recent video where he claims hard plaque is not safe? Yes, I would be happy to look into Anthony J's recent video. I don't have any knowledge of that to share right today, but maybe we will put a pin in that and also think about that as part of a comment response or even its own reaction video coming to Knife Down near you in the future. All right. Donut time, Dr. Lilly, regarding your book, what message would each take away? 1, kids wanting to become doctors. 2, med students in the middle of it. 3, board certified decade-long doctors in the middle of it. All right. I don't know that kids wanting to become doctors will take away. So the book is called Disconnected, and it is the story of kind of my journey through my training, through my first full-time job, and kind of having this moment of recognition that I was really unhappy practicing in the way that I was at that time, and like, what was the problem? Because when I looked around, I saw that there were a lot of other doctors in my life who were about my age and my stage of training or career who were also kind of unhappy. And I wondered, like, was this just a me problem or was this a much bigger problem? I, as a medical student, was pretty naive about what I thought the practice of medicine was going to be. Both my parents are physicians, so I thought I had some understanding of what I was getting into, but I didn't. And like a lot of young people, I thought I could take a look around and understand what the landscape looked like, and I would have boundless energy and be able to, balance all of these things, and I would be fine. And I think a lot of people early in training have that same enthusiasm, right? They're just so excited and passionate about this opportunity to help and serve and to get their hands dirty in the practice of medicine and like get right in there and do stuff. Like all the administrative stuff doesn't seem as relevant. It feels like those are surmountable challenges if you just work hard enough and are passionate enough about the medicine. So, I don't know that a med student is going to read this or a kid is going to read this and think, not for me. I won't do that. Even a med student, second part of your question, I'm not sure if they will be able yet to appreciate the cost ultimately that it will take. I don't think that if I read this as a med student, I would have thought it would apply to me. It might have taken up residence in the back of my brain as like a little niggling thought and something that I would come back to later, but I'm not sure I would have had the humility as a medical student to actually get this. So mostly the book is for anybody who touches healthcare today and is having a bad time of it already. So if you're already kind of disenfranchised, then maybe this begins to speak to you. If you are still in the idealistic phase of your training or of your career, that's awesome. Like lean into that for as long as it's possible for you. Some people, I think, never grow out of it. I know a lot of other doctors my age who are actually quite happy and satisfied in their careers. It's not everybody. But if it is you, then I think you walk away with some understanding of why it is that you feel this way. And you also walk away with some ways that the system could change, hopefully in the future, and we can maybe organize together to help facilitate that. and what you can do in the meantime to survive. So thank you for that question about this. We will circle back to disconnected at another time, but thank you for giving me the chance to talk a little bit about it here with you all. At Billy Boy, can I talk about Bale Doneen for a minute? I use them. I like their approach, but I think they give short shrift to lipid particle size. Thoughts? I don't know entirely what you mean by short shrift to particle size. I think that particle size is an interesting thing, particularly as it may contribute to the LPIR score. So that is LabCorp's proprietary lipoprotein insulin resistance score that uses particle sizes from the NMR part of their testing to help adjudicate signs of insulin resistance related to lipoproteins, which may or may not track super well with HOMA-IR, depending on, other issues. But the mainstream lipidology community is no longer all that interested in particle sizes. They are interested in overall total particle burden and not so much the sizes anymore. Does that mean that they're not totally relevant? No, it just means that in general, if you're reducing total particle burden, that's actually a much easier target than just reducing the small dense LDL particles or the oxidized particles. Like the easiest way to move that needle is actually, in the opinion of general lipidology community today in 2026, to just reduce total particle burden, because proportionally you will also reduce those, even if the ratios may change a little. Generally, you're going to have fewer total particles and then fewer of the most atherogenic particles. But just because the bigger particles are potentially less atherogenic doesn't mean they're not atherogenic. And if we have them in high enough numbers, they may still pose a problem. Now, will they for everybody? Probably not. Does it matter what other risk-enhancing factors you have? Polygenic risk score, strong family history, insulin resistance, toxic exposures, inflammation. Yes, probably all of that is also relevant. And what I like about Bale Doneen is that much more holistic approach to thinking about all those other components and making sure that most of those can also be evaluated and potentially addressed if they are relevant. So that's what I like most about Bale Doneen. And for those who are not aware, Bale Doneen is a more general approach to cardiovascular risk reduction and event prevention. And it was created by Dr. Brad Bale and Amy Doneen, nurse practitioner. They have kind of this proprietary type system, or mostly a framework for how they think about all the myriad risk factors for the formation of plaque and the rupture events that come from plaque. And again, I adopt probably 85 to 90% of what they have taught and continue to teach. I think they are continuing to evolve as well, and I like that. So I don't know if I will be able to go to their preceptorship this year and learn more from them again, but initially I found their whole framework pretty helpful. They do have a couple of books that I think are also reasonably accessible for a non-medical trained audience. And so Healthy Heart, Healthy Brain is the most recent one. That's pretty good. I listened to it on audio, and that's a way that you could kind of get to know more about the Bale Doneen approach if you are interested. Certainly, they also have a website and a directory for providers if you are looking for a Bale Doneen provider near you. They also have a very strong emphasis on dental and oral health. So there are actually a lot of Bale Doneen dentists that are listed in that directory as well, if that is a consideration for you. All right. At V. Derricks, is an AI overlay worth it if a CCTA for an early 50 male shows no plaque and a CAC of 0? So kind of depends on how high your pretest probability is, which means how much risk is there in your family? How many other risk factors do you have? When I see a radiologist read that says no plaque, and I actually had a patient like this recently through my clinic, where the radiologist said no significant stenosis and no significant plaque, but the AI overlay actually did detect some early soft plaque. There wasn't very much. It was less than 30% narrowed or stenosed, and the radiologist didn't call it. But again, there is some evidence, and when they do the reconstructions, it actually is visible to my eye. So I believe that actually represents a real finding. But it's a pretty steep investment to do that. What I would say is, it would give me more confidence that if you wanted to repeat the study in 5 years, that you would have a good basis for comparison. But you could submit 2 studies in 5 years, right? If you have your CDs from now, then you repeat your test in 5 years, you submit both. However, if you found that you had some soft plaque now that didn't rise to the level of any narrowing or stenosis from your radiologist read, but there was some early disease, like, would you do something differently based on that information? If you think you would do something differently based on that information, then maybe that's worth it to you to go get it. Maybe you just have curiosity about what that would look like and whether there's anything there to detect above and beyond what the radiologist naked eye can see. Might be interesting and a fun thing to pursue for that reason. Is it going to kind of meaningfully change your clinical course in the next 5 years? Probably not, right? Whatever plaque burden you have, if any, I don't think it's going to be significant enough to rise to the level of necessitating any kind of intervention, right? No stent, no operation in the next 5 years. But could there be some disease there that might change your threshold for how aggressive you wanted to be in your lifestyle choices, in your other risk factor mitigation efforts? Maybe. So I leave that a little bit up to you, but I would say there is a, probably up to I'm making this number up. I have no idea exactly what the probability is that there is some plaque there that a radiologist didn't find, but it's not 0. That's as confident as I can be. All right, Tahoe style. I'm going for an age-related ultrasound to check for abdominal aortic aneurysm. Do I know much about it or how common it is? Yes. So that is something, again, that as a vascular surgeon, I see and help manage pretty frequently. It's actually not terribly common. The screening is offered currently for any man over age 65 who has ever smoked in his life. Usually ever smoked means 100 cigarettes in a lifetime, but I would say people are pretty loose on that definition. And if you smoked enough to think of yourself as a former smoker, by all means, go get that ultrasound test. Because they're slightly less frequent in women, even though I would sort of recommend screening for women who have ever smoked as well. It does not rise yet to the level of being a guideline, so may not be covered by insurance for that reason. But ultrasounds are relatively inexpensive. They are radiation free, and they are a great way to detect the presence of that. But if you've ever had a CT scan of your abdomen and pelvis, or even of your back, you probably have a picture of the aorta in that range somewhere in that area, and would be able to know that from those pictures too. An X-ray won't cut it. You won't be able to see it on an X-ray, but if you've ever had a CT scan or even maybe an MRI, depends on where exactly they were taking pictures, but you might be able to know it based on those images as well. If you have an abdominal aortic aneurysm, should you get it fixed? That is actually really dependent on how big it is, because the idea of an aneurysm, okay, so the artery usually goes like up and down with parallel walls in a straight line. So blood is kind of flowing head down into the abdomen and pelvis, and the aorta is the biggest pipe that leaves the heart and delivers blood flow to the rest of the body. When the wall of the aorta gets weak, and tobacco is the biggest risk factor we know of for weakening, but long-standing elevated blood pressure, some kind of inherited diseases can do this as well. The pressure that is continuously pushing on the wall of that artery will actually continue to expand part of it, and it balloons out over time. And the way I describe this to patients is kind of like a water balloon. When a water balloon just has a little bit of water in it, it is very soft. It is very durable. You can toss it around. You can drop it on the ground. A minimally full water balloon doesn't really pop. Like, you'd have to work very hard to get that to pop. A moderately full water balloon has more stress on the wall. The wall of the balloon gets a little bit thinner, and you can still, usually like toss a water balloon to somebody, 20 feet away, and like probably if they catch it, it won't burst. But the fuller that balloon gets, the weaker the wall gets, and the more fragile the whole thing becomes. And there comes a point where it's so full that, if you just blink at it funny, it's going to pop, right? And this is the same kind of concept with an aneurysm. When it gets to a point where it's kind of medium full and we start thinking about, the possibility of it bursting or rupturing, if that happens, you bleed internally, and that can be a fatal event. So we'd like to prevent that. On the other hand, surgery is never risk-free, right? Even great surgeons, even minimally invasive approaches, there is always some risk to an operation. And not all aneurysms continue to grow over time. Some will grow to a small degree and then stay that way indefinitely. And as long as they stay small, they're like that underfilled water balloon. They're really, I mean, they don't look pretty, but they're not going to rupture and burst and take your life. At which point, it's not really worth the risk to do the procedure or the operation to fix it. So, after studying thousands of patients across the world, the magic numbers are 5.5 centimeters in men and about 5 centimeters in women. Just because we're a little bit smaller and proportional to our body size, the 5 centimeters is about where we think that the risks of fixing it are now lower than the risks of it eventually going on to rupture. Does not mean that a 5.5 centimeter aneurysm in a man is really high risk for rupture. It just means that that's really about the sweet spot where risks of surgery are finally outweighed by the risks of the aneurysm. But people come to me with a 4 centimeter aneurysm and are like, Doc, I'm walking around with this ticking time bomb. You got to fix it. It's uncomfortable to have it, but at that point, there are so few aneurysms that rupture at that size that it's really not worth the risk, right? Like very, very, very uncommon. And usually there are special characteristics, like they come from an infection. They're not this ongoing degenerative, long-standing chronic process. And so we check an ultrasound or check another CT scan in a few months and see what's happening. If the rate of change or the growth is high, then yes, we will proceed with fixing it. If patients are symptomatic, they have pain, then yes, we will fix it. If we think there's something funny going on, family history, infection risk, some kind of connective tissue disorder, all kinds of reasons why we might choose in some particular scenarios to fix it at a smaller size. But generally speaking, all comers, run-of-the-mill atherosclerotic degeneration of the wall, 5.5 centimeters in men, 5 centimeters in women. All right, I think we've done AAAs to death. At Judith Joseph, if cath angiography, the doc says your troponin is elevated, but no blockage, what caused the event? Called Minoka. 7 years old, previous MI. So this is not an area that I am as familiar with. Thanks for the love, guys. But you know, this is a like non-ischemic or non-obstructive, excuse me, cardiac event. And typically we think of that as like maybe vasospasm or a very small vessel disease. So part of this is all of the blood vessels that have names are kind of a certain size, but the blood just doesn't leave the big named coronary artery or the big named tibial artery. Coronaries would be the heart, tibials are the lower leg, and they go straight into the tissues. The arteries get smaller and smaller and smaller and smaller until we're in a capillary bed. And that capillary bed is where the tissue exchange really happens. And like those vessels are not that much bigger than the blood cells that flow through them, right? That's how we get this exchange gradient of oxygen and the nutrients and all of the things in the blood. But those vessels are very, very tiny and they don't have names, but they are equally susceptible or sometimes even more susceptible to damage than the bigger ones with names. But the smaller ones we can't fix. But if they are not working very well, then we still ultimately have a problem with the ability to deliver oxygen, to deliver the nutrients that the tissue needs. So what do you do about that? And first of all, what damages that? Typically, that is, diabetes is like the biggest cause of small vessel disease, certainly in the feet, which is where I see it the most. I think also that is probably true in the heart, although again, not a cardiologist, don't play one on television. We just talk about a lot of the same pathophysiology, but this one's a little bit more specific to the heart. So I'm out on a limb just a little bit here because it's really not my area of expertise, but vasospasm, where the arteries are just super reactive and they like clamp up, that can do it. And also there can be intrinsic damage to the very small vessels in the heart. So you may not have plaque or blockage in the bigger ones, but the small ones could still be damaged and could still be impacting the muscle's ability to get that oxygen and that nutrient that it needs to function optimally. So you can still have damage to the muscle tissue, which is the heart attack, without necessarily having blockage at the level of the big named vessels. All right, at Tom Smith, Dr. J's video was good. If we agree with Dr. Malcolm Kendrick, clotting in the arteries is the main problem, then think about how many people are on blood-thinning anti-clotting drugs. Yeah, Tom, that's an excellent point, and I think about this a lot as I think about Dr. Kendrick's work, right? We know that, yes, there is absolutely a component that is helped by being on antiplatelet or anticoagulant drugs, both of which are colloquially thought of as blood thinners, although they do work a little bit differently. I don't think that, we have so many people on those medications who still go on to have events. So I really don't believe that, making the blood thin for everybody forever is the answer. And if we go back and look at like the aspirin primary prevention literature, the risk reduction was not as impressive as we thought it might be or that it should be. Now, you could argue that two ways. One way is it's not sufficient, right? It's aspirin alone is not enough anti-clotting oomph to prevent the events, right? The plaque rupture clot cascade that happens, or the microclots that actually cause the plaques to form and grow over time. But again, now we have so many people with atrial fibrillation who are on these anticoagulants, and we have people who are on Plavix, and they still also have events. So again, is it that the inhibition is inadequate, or is it that there is another process that's ongoing? And I don't know that I am quite prepared to like weigh in on that with a number of different papers and studies right now today. But I think it's a very interesting point that probably should come up in a future debate, for example, that might be happening on this and another channel in the very near future, coming soon to YouTube near you. All right. Termy Cobra, had my Lp(a) tested on my own dime after my VA doctor said I didn't need it. My results came back at 7.3 nanomoles per liter, which is super low. Yeah, so I'm glad you had this tested. I am sorry that your VA doc didn't do it. It should now be in the guidelines, and hopefully that will trickle into the VA and all the big healthcare systems, right? I don't want to single out the VA. There are still a lot of docs in other practices who are not routinely checking Lp(a) for people. But that is now in our 2026 guidelines. It should be at least checked once in a lifetime for everybody. And if you are positive, then your siblings and children, immediate relatives, should also be screened for that. At least all the docs in the ER I worked with mentioned how medicine isn't what they thought either, on the same train of thought. Yeah, it's a tough time to be a doc, and I don't want to like complain too much because we are still very lucky to do what we do and have the opportunity to help and serve. But the cost, I think, to us is a lot higher than it used to be. And somebody was asking me about the TV show The Pit earlier and whether I had seen it. I actually have heard really good things about it, but I've also heard that it is so true to life that people who are kind of living a tough life as a doctor or as a clinician are actually kind of a little bit triggered by it because it is so gritty and representative of the everyday experience that we're already having, that it's actually sometimes a little tough to watch. So I have not yet quite had the fortitude to pull that up and go through that, even though I've heard such great things about it. And even though Noah Wiley has done a really, really good job recently in part of the advocacy effort for mental health and for supporting doctors, nurses, and everybody in clinical medicine on the front lines to have improved working conditions and a better experience. His mom is a nurse, and he is really passionate about helping bring this message forward and using the Pit and other, I mean, he was an ER back in the day, right, too. So it's been really fun to sort of watch his career in medical drama and to use that platform as a vehicle to help advocate for us. I am so grateful that somebody is, who's not a doc, but is just watching it from the perspective of somebody who loves a clinician, right? Loves his mom, a nurse, and watching what is happening to healthcare and is willing to help kind of promote a better future for us. So Noah, thank you for that. We really appreciate you. Charles Patrick. Can lower leg venous insufficiency in otherwise healthy people who are normal weight and exercise regularly just be age-related, like wrinkles, or have a genetic component? Yes. So venous insufficiency. So veins, right, bring blood back from the end tissues back up into the heart. So the way I describe veins are a gravity problem in the legs. Blood has to get from the feet back up to the heart. Veins, unlike arteries, do not have muscles in their walls themselves. They cannot pump blood. They rely on either gravity or the surrounding muscular tissue to push blood back where it goes, where it belongs. So in the legs, the blood is squeezed back up through the veins when we walk or when we contract the muscles. So when you walk, the muscles squeeze, blood shoots up kind of like toothpaste out of a tube and goes back up to the heart where it's supposed to go. But then when you relax your leg muscles, right, you're going to step with the other leg, you're going to sit down on a park bench and enjoy the scenery. Well, then gravity starts to take over, right? And gravity now wants to pull that blood back towards the floor. What is supposed to happen? There are these little one-way flapper valves on the inside of the veins that are supposed to, as the blood begins to fall, flap shut and hold the blood at this level until you step again or squeeze the muscles again, and then it, goes back up in one direction. In venous insufficiency or leaky valves, the flapper valves either don't work very well or they are stretched out, and so blood is allowed to fall back to the floor with gravity despite the best intentions of the body. And when this happens, the blood begins to pool and it expands the veins, like they get stretched out, trying to accommodate more and more blood as the pressure of gravity pulls more and more blood down there. And eventually, the veins dilate and become these varicose veins. You can also get some skin color changes. It starts to look very tan. That's actually the blood that has leaked out of the veins and some of the iron in it. Hemosiderin is the name for it, and it's a sign of chronic venous insufficiency. There can be skin changes. There can be swelling. Vein disease is mostly a big nuisance. If it is very severe, it can absolutely be a severe medical problem if there are wounds and ulcers associated with that. If the swelling gets so bad that the skin actually is compromised and begins to break down, that is a very serious manifestation. Most people, well over 90% with chronic venous insufficiency, never progress to that level. They have legs that are achy, tired, itchy, painful, and often that can be managed with leg elevation and compression socks or compression garments. Some people will choose to have the visible varicose veins or the tributary that they come off of, typically the great saphenous vein, will have those treated surgically. I always warn patients for whom I might be, I don't currently do any vein work, but I used to do a decent amount. Varicose veins will come back over time if you are not a little proactive about your compression, even after surgical treatment, even after a saphenous vein ablation or stripping, ligation, however you are being managed. The same factors that cause them to form in you in the first place will cause them to form again over time if you're not a little careful about how you treat your legs. In general, it does tend to run in families, and people who are putting more gravity stress on their legs will also potentially see it. So I wear compression socks a lot of the time because I am standing a lot of the time, or even sitting some of the time. And in both of those cases, right, my leg muscles aren't moving as much. I'm not getting as much of that boost back to move the blood. And so, yeah, gravity is taking a bigger toll. So people who stand in a lot, teachers, warehouse workers, doctors and nurses, like all kinds of folks who are on their feet all day are also a little bit prone to this. But I also will always ask about family history and oftentimes hear that, yes, mom had this or dad had this or dad and his brother and all my cousins, right? So there's absolutely a component that is family related. I don't think everybody gets it. It's not like vision changes where like vast majority of people, if you live long enough, will have some need for, readers or something like that. But, over time, certainly there is more stress on the body. And again, anything that increases pressure will increase the stress. So as you mentioned, right, even though you are normal weight, right, if they had ever been overweight at one time, that can do it. History of blood clots can also potentially do that and be relevant. So it's super common. And again, a lot of people can just really manage the symptoms once they know it's not dangerous with compression and elevation. And surgery is really about symptom management. It doesn't measurably change the risks of anything bad happening to your leg or your life over time. It doesn't really change the risks of like developing a severe blood clot in the deep venous system. Most chronic venous insufficiency is in the superficial venous system. I kind of skipped over that part of the lecture, but Treating the superficial system doesn't change your chances of developing a deep vein blood clot. So we don't do it for any kind of medical prophylactic reason, but we do it because symptoms are really bad and compression is sometimes not always feasible or tolerable in the time and dose that would be required to help manage those symptoms. So let me know if you have more questions about vein stuff. Again, it's not an active part of my practice right now, but I did it for a while and super common. All right. At CD Prince, for people who have non-zero calcium scoring or known soft plaque from a CCTA, how valuable do you think inflammatory testing is? For example, glyc-A, myeloperoxidase, LPPLA2, fibrinogen, OX-LDL. I do some of this. So hsCRP, high sensitivity C-reactive protein, is probably the most well-established inflammatory cardiovascular risk marker. It's what's been studied more predominantly in a lot of the randomized controlled clinical trials. I think that LPPLA2 and myeloperoxidase are both up and coming as markers. LPPLA2 tracks a lot with particle size, and whether it's hard to know how to intervene on that directly. MPO, I will sometimes check as like a marker for periodontal disease. The Bale Doneen folks, for example, will recommend MPO testing in a spot check way for that. I have gone away from routinely checking it in all patients just because it's a little pricey, and most of the time it's not going to move the needle in how I treat people. So fibrinogen, again, hard to know. I don't check it in everybody. OX-LDL is interesting from a research standpoint. Again, how do I move the needle on that? Typically, it's by reducing total particle burden rather than like oxidative stress per se. Glyc-A, I think, is very interesting. I'm looking to start incorporating that more in my practice. I think it's a separate measure from hsCRP that may provide some additional details. When I'm thinking about inflammation, where I really want to go with this is why do we have inflammation? And again, I've been checking and following my hsCRP for a while. It was quite high. It's now down lower. Most of the time in my practice, the biggest root cause for inflammation tends to be visceral fat, visceral adiposity, fat around the organs. And that's usually an excess energy or an insulin resistance problem. So that is a good target for that. That is also something that, you could probably get with a waist measurement or waist to hip ratio and know from body composition analysis rather than even just checking inflammatory markers. But we certainly know hsCRP does track with cardiovascular risk, and it's interesting from that perspective. But there are some other important sources of ongoing inflammation. Again, a subclinical abscess in the mouth right above a root canal can be responsible. Severe periodontal disease can be responsible. Maybe heavy metals could be responsible. I've heard other providers talk about that. I have actually not diagnosed that in any of my patients specifically. Sleep apnea and chronic stress could be part of this, right? There are a lot of different components. I don't necessarily ever know for sure. Most of the guidelines would not suggest continuing to track these things as like a therapeutic target. They suggest measuring them for risk assessment, right, at sort of a baseline time zero, but they're not really recommending that like you then choose to intervene, right? That you're gonna give people colchicine and then recheck and see if it helped or do any of these other things. Statins, of course, from the Jupiter trial are purported to help reduce hsCRP, at least in that particular intervention. That was one of the pleiotropic effects that is often brought up with statin therapy, and one reason why they may be effective in reducing events, particularly in secondary prevention populations, higher risk populations. All good questions. I do think inflammation is relevant. There was a press release recently about something called the ZEUS trial, which was a very large trial of a monoclonal antibody that was given to reduce interleukin-6. And it worked to reduce interleukin-6. It worked to reduce high sensitivity C-reactive protein, but it did not actually have any reduction in major adverse cardiac events, according to the press release. Now, we don't have the data yet. They've not been presented, but everybody is now all up in arms that, well, it's all the lipoproteins. Inflammation was never relevant. The data for inflammation have been mixed anyway. Let's forget about that. It's not a druggable target and go back to focusing on lipoproteins. To which I say, I mean, let's think about it. Let's talk about it. I do think that there is mechanistically something interesting and relevant about inflammation. Does that mean that we should have a pharmaceutical target for a very complex system in our body that regulates our whole immune system and function? Maybe not. I think maybe thinking about root causes here is something that could be more helpful. Not super well informed by the evidence, but that's my personal philosophy on it, and that's kind of where I think we should go with that. All right, let me pop over to some of our anonymous questions here for a second. My video with Todd of Cardio Risks highlighted tech-dependent aspects of CIMT. So do I recommend going to CIMT even if they don't have the same technician for follow-ups, or see another CIMT certified technician farther away whom I can see for follow-up tests? So again, if they are certified by CardioRisk, then ostensibly we are all following the same protocol, and that protocol is what gives us a high degree of reproducibility and reliability. Is there an advantage to minimizing the variability where at all possible? Sure. But I would say if it's all CardioRisk, I feel reasonably confident that your at least IMT measurement is going to be pretty reliable and repeatable. If it is not CardioRisk, then I would say I have no confidence one way or the other, right? It might be okay, it might not be. Just don't know. Depends on how they're doing their scans, what their protocol is, but I wouldn't really feel great about comparing one to another. If it's all the same cardio risk-based protocol, I think that's much more helpful and likely to be reasonable and productive for you, even if it's not the same tech. How much stock do I put in an elevated MPO at 1190 for cardiac risk if other markers of macrophage recruitment and plaque, like LPPLA2 and OX-LDL levels, are within normal range, and overall low 10-year risk scores on both Reynolds and Framingham scale? Yeah, again, we're talking about kind of one isolated marker of inflammation or cardiovascular risk in the absence of other things. Hard to know how much stock I would put into that. Again, as I mentioned just recently, I do think of MPO as sort of how I think about high risk oral health issues. So if there is, I don't think I see an HSCRP in that question anywhere. If HSCRP is also elevated, maybe get a cone beam CT of the mouth if there's any old root canals that could be hiding a subclinical abscess. If you have periodontal disease, or you're not sure, go ask your dentist to get your pockets checked. And if you have gums that bleed when you floss, then go think about that, and maybe think about working on oral health and hygiene as part of general risk reduction strategies. Again, there's a very strong association with periodontal disease and cardiovascular events, more strong than I think most people really recognize. Whether that means intervening on it will reduce your risk, we all hope that it will, and we think it's a good idea for your general health and well-being anyway, but the evidence for intervention, not as strong as you would hope. So that's probably where I would go with that MPO. All right, and next anonymous question. What piques my interest or concern in the labs below? What possibly needs focus? Clinical background is a coronary calcium score of 500, heart failure with reduced ejection fraction of originally 45%, now 59%, which is a normal ejection fraction on beta blockers, statin, and aspirin. So let's go through some lipid numbers here. Again, none of this is medical advice. I'm just sort of offering what I would do in a patient under similar circumstances, but please, I'm not your surgeon. I'm just a surgeon. Go find your doctor and check with them, but let's go through this. Total cholesterol, 102. LDL-C is 54. HDL-C is 34, which is still low. Triglycerides are 61, which is great. ApoB is 61, and LP(a) is 12, which is great. So for somebody with known plaque, the LDL-C would meet current guideline standards for high risk, which is 55 milligrams per deciliter or less. Triglycerides are under 100. I think that's great. HDL-C is low at 34. Hard to know how to move the needle on that. We'll see if there are sort of any other markers here that might be informative. So LDL particle count is over 1,000, which is a little higher than we might like to see it. Small LDL particles are high at 735. So now I'm starting to get tweaked about an insulin resistance picture here, and that makes me think about possibly some lifestyle interventions that might need to happen to maybe further optimize this. Our LDL size is 20.1, which flags as small, and HDL particle number is low. Large HDL particle count is low. HDL size, VLDLs, LPIR, so lipoprotein insulin resistance. This is a proprietary model that is run on the LabCorp version of these NMR, nuclear magnetic resonance, high complex lipid panels that takes into account the particle number, particle size of the remnant particles, the HDL particles, and makes an assessment of insulin resistance based on these lipoproteins. So the LPIR score of 46 is moderate. That's going to be about, depending on age, I think that's, less than 25 would be optimal. 25 to 50, I think, is sort of in that median range, which means I think there's room for improvement there. It's not the worst I've ever seen by far, but I'd love to kind of move that down from 40s into 30s or 20s even would be great. CRP is less than 3. That's probably not a high sensitivity C-reactive protein because they ought to give you a number. If it's between 1 and 3, that's average. If it's less than 1, that's optimal. Homocysteine is 11.2, which flags as normal, but in my practice, I would manage homocysteine at that level. I think optimal is actually less than 8. I would accept less than 10, but if we're higher than 10, I would actually consider managing that with usually methylated B supplementation. Fasting insulin of 7.3, they're calling that optimal. I disagree. I would love to see a fasting insulin of less than 5 or less, call it. A1C is normal at 5.3. which is translates to an estimated average glucose of 105. Uric acid is fine at 5.2. B12, vitamin D, zinc, CoQ10. That CoQ10 level of 0.42 is, again, CoQ10 testing. Should we do it? I don't know. I test in some patients. This is going to be a totally unsatisfactory answer. I test in a lot of patients. And I think probably the optimal number is like somewhere between 0.8 and 1. But again, don't have great papers to support that. But if you're having any issues on your lipid lowering therapy, you might consider CoQ10 supplementation, or I might offer CoQ10 supplementation to a patient at that level to see if bumping it up would make anything different or better. Ferritin is low at 21, so that's indicative of iron storage deficiency, and you may feel a little better with some iron supplementation, unless that's done intentionally for any reason. Total serum iron, which is not a very helpful lab, flags as normal. That's fine, but your ferritin stores are low, and your thyroid stimulating hormone of 1.89 is normal. So overall, looking at that lab panel, what I see there is mostly, I think, insulin resistance is what I am getting the big gestalt about. Homocysteine's a little elevated. I'd probably treat that too. But I think probably the biggest bang for buck is going to be working on figuring out how you want to manage your insulin resistance, because I do see evidence of that in that lab panel. All right. Donut time. I thought this whole AMA was about the book and all about me. Let's focus on me. I'm very important. Thank you so much. You are so sweet and kind. I am so grateful for my audience. You guys are amazing. All right. Kujai, can I talk more about microvascular dysfunction? I'm in a drug trial with ranolazine and losartan. I can still run, but chest pain comes and goes. Should I seek a specialist like Mayo? I would love to talk more about microvascular dysfunction, but that would mean that I would need to know more about microvascular dysfunction. And I'm feeling like I'm just out on a limb and not super confident in telling you more about that. It's just not something I know as much about as I wish I did. What I would say is seeking a second opinion, whether that's all the way at Mayo or, whatever's nearby, is like never a bad idea. I actually am always very encouraging if my patients ask me about second opinions or want a second opinion. I think that's really important. I think you should have as much information as a patient as you need to feel confident and comfortable in your decisions. We don't know as much as we wished we did. And even though I might give you an opinion, maybe it doesn't make sense to you. Maybe you want a different surgeon with a different perspective, more experience, different training, all good. There are a lot of right answers to some of these questions. And as a patient, you get to pick the one that feels most resonant for you. Because again, all of us, I believe, right? I would say 95% of physicians are operating in a space that is like medically reasonable. That doesn't mean we're all going to give you the same answer. There are sometimes many medically reasonable solutions to a problem. But what feels right for you and for your goals and for your satisfaction that you have as much information as you want and need to move forward with your life, like those are different questions. And I, like you probably get multiple quotes if you were going to have somebody do something really big on your house, like fix a roof or, renovate a room or something like that. Like you wouldn't just pick the first contractor. So again, making this work and making it make sense with insurance is like a whole separate part of the problem. And I wish I didn't have to even say that, but that's irritating. Nevertheless, I would love to say that you should think of your health just like you think of taking care of your house, and like get multiple perspectives, get multiple quotes for what you're going to do. Not because the pricing should be different, but because people come with different skills, different perspectives, different experience, and may just say it in a way that makes more sense to you, or you may have a better rapport with one particular clinician or another, right? Like we're all just human beings on the inside of that white coat, and you deserve to like work with somebody that resonates with you and that makes sense to you and you feel like is going to hear what you have to say and take you seriously and answer your questions and like be a good partner in your care. So absolutely get a second opinion, get a third opinion. And I don't want to say like go shopping, right? Don't go doctor shopping until you get the answer that you want to hear exactly. But again, nobody will ever be as good an advocate for you as you, right? No doctor will ever have the skin in the game that you do. So this is important. This is life or death. Like find a clinician, a doctor, somebody, a partner that you can work with that is going to help you get where you want to go. That's what I want to say about that. Okay. Waiting for the cats to arrive. Yes, they are busy wreaking havoc elsewhere in the house. I don't know what I will find when I go hunting for them later. We will see. All right, ManGR. Just watched Dr. Carveo comment on the vitamin K2 craze that less calcified plaque isn't necessarily better because it's soft plaque that ruptures, which I found fascinating. Nuance is important. Yes, exactly. So we have also talked about that K2 paper here on this channel. And again, we just don't know what it means to have less calcification, right? Does it mean that there's less plaque burden overall? Does it mean that there's more soft plaque that might be prone to rupture and we're not stabilizing as much? We just don't know yet, right? We don't have the outcomes data to show us what is happening, and we don't really even have as much of the information on the CT angiography side with the soft plaque imaging that would help us adjudicate that in a better way. They did some of that in that trial, as I'm remembering. I haven't read it super recently, but I remember walking away from that paper thinking, first of all, the impact on calcification, this is the first time we've shown it really clearly. There have been a couple other studies that showed it in subgroup analyses, but this is the first one, and K2's been pretty extensively studied. This was the first one that showed a dramatic reduction in calcification in the whole study population. So that was kind of interesting because it's not as profound and uniform an effect as you might have expected, but also we just don't know what the impact on clinical outcomes is, and that should, at the end of the day, really be where we need to focus. Until we have that information, I still generally think it's not a bad idea to take a modest dose along with D3, mostly because of the impact on bone health and the ability to shuttle that calcium where I want it to go, which is into the bones. But I'm not necessarily recommending it because I think it is going to prevent pathologic calcification in the artery where it may or may not be doing anything useful, right? We just don't know. So stay tuned for more information on K2 as the data evolve. All right. Tom Smith, book pre-ordered. It is $67 in Australia. That is pricey, and I thank you so much for supporting the book. Thank you. You warned your daughter about becoming a doctor several years ago. Did she become a doc? Like, what did she decide to do with that warning and that information? I'm curious. Now we need to know more. James, welcome. Hey, James. Thoughts on sphingomyelin being both an emerging structural promoter of arterial plaques and biomarker, implying future therapies to target aggregation, alternatively to simply lowering LDL. So there is this whole other category of molecules, and like ceramides, I think also fall in this category. We were thinking about doing a video on ceramides here shortly, but there are other kinds of lipids or fats that float around in our bloodstream, in our cell membranes, and that are relevant to the cardiovascular risk picture, right? We know about omega-3 fatty acids, how that may be relevant to plaque formation, atheroma, risk, all of these things, triglycerides, remnant particles. But also there are other categories of lipids, sphingomyelin, ceramides. And what we are learning is that they also seem to be important. And some of this is a component of dietary intake, like what are we eating, whether that's inflammatory, what kinds of fatty acids we are ingesting. Some of it may be what is happening kind of on the post-processing side, like what the body is doing with the energy that it's getting and with the fatty acids that it has. So I think this is a very, very interesting space. I think it's very early. We don't know enough about this. I am just getting into starting to test ceramides for my patients. I have not yet done a lot of repeat testing to see what interventions are going to be helpful. And, mostly right now I'm relying on some of my colleagues to help me kind of interpret these tests and think about how to help patients move the needle on this. Right now, I'm not sure how much of an intervenable target it is, right? Again, some of these things we measure demonstrate the presence of risk, but trying to fix them doesn't necessarily mean that we're going to reduce that risk. We just don't know yet. We hope that they will, right? Some of the ceramide studies have shown that yes, if you can eat more like high polyphenol olive oil and you can lower your ceramide, your high risk ceramide components, then perhaps, yes, there's some reduction in events. Again, as we get more and more detailed in our ability to look at metabolomics, proteomics, some of these very fancy molecules that we have circulating around, like sphingomyelins, we'll probably figure out more about this. I am not an expert by any means right now. Maybe I never will be. There's just so much to keep up with and learn about that sometimes it's overwhelming, but I think this is probably going to be an interesting area of lipid biology, above and beyond lipoproteins. And I will be very excited and curious to see where it goes and hopefully be able to bring you some more information on the channel as I get smarter about these things. All right, tech. I found Dr. J's video interesting, albeit a single source. Not sure Dr. Kendrick is in 100% agreement, but both pretty much dismiss LDL as causal for ASCVD. Yep. I wonder how many cigarettes a child smoked via secondhand chain smoking parents who kept car windows rolled up. Yeah, I don't know that either, but I think it's more exposure, and certainly more exposure at a vulnerable period in life than is optimal. I don't know if we have any way of quantifying that, but certainly asking about secondhand smoke exposure is probably something I don't do often enough. All right, Tahoe style. Great news. I had an MRI of L3, L4, L5 that might show the aorta. Yeah, some MRIs, right? The aorta sits right in front of the spine, and so sometimes you can actually see enough of the aorta to make that determination. Sometimes the way they crop those images, you won't get the whole aortic wall, and so that might be kind of frustrating. But usually, so sometimes as a vascular surgeon, I'm asked to help move stuff out of the way. And by stuff, I mean the blood vessels that sit right in the front of the spine to allow the spine surgeons to get where they need to go. And generally speaking, there's enough of that visible on an MRI of the spine, which was obviously done for the benefit of the spine surgeons. But usually the poor little vascular surgeon can also get just enough information to be able to see kind of where stuff might be. So I do think that you'll probably be able to decide if there's an aneurysm based on that imaging. I hopeful. All right. James, you are the GOAT. Thank you. Do I think Mendelian randomizations are smoking gun for LDL ApoB being one causal factor? Only pushback I've seen is horizontal pleiotrophy. Yeah, so I think as somebody who has been kind of some ways cornered a little bit more into like defending the lipid heart hypothesis than like I am certainly no Tom Dayspring. I am not as bullish about this as many of the folks here on social media are. And I like having some nuance in my perspective. My read is that Mendelian randomization is one of many different lines of evidence that are all coalescing to a place that tells me that lipoproteins and ApoB in particular are relevant, but probably not the only thing, certainly not the only thing, that is relevant to the formation of plaque in the artery wall. I think personally that plaque formation in the artery wall is the end result of a number of different types of insults. And for some people, atherogenic dyslipidemia, meaning elevated ApoB and other remnant particles that might be, or other particles that like Lp(a), which is also an ApoB particle. All right, let's just call it ApoB. That are contributing to formation of this atheroma, these fatty streaks in the wall of the artery that then, create this inflammatory local milieu where all the junk builds up and they have these plaque rupture events. I do think lipids are relevant for some people who have this, but I have said it before, I will say it again for the record. If ApoB were the only thing that were relevant to cardiovascular disease, we should have been able to cure this or at least make a way bigger dent in it than we have. And we should have been able to do this a decade ago, right? We've had lipid lowering, ApoB lowering agents for a long time, and we have millions of people who are on them who are still having events. Patient in the hospital who I have been following as a prevention patient, and like, say what you want about all this, right? He, despite my best efforts, still had a stroke, and he is on Repatha walking around with an LDL-C in the 30 milligram per deciliter range. So, obviously it wasn't lipid lowering alone that was responsible for the progression or the plaque rupture event that he had. Something else did that, right? And I have some theories and some ideas. I will never be able to determine what it was, but he was on goal-directed medical therapy for severe atherosclerotic disease. He was on his aspirin, he was on his Repatha, his lipid lowering, he was at goal, he was well below goal. So something else is going on, right? This is not the only answer to this problem. And I do find the Mendelian randomization data compelling as a separate line of evidence, right? It's not like we are relying entirely on the MR studies to further this hypothesis. It is one of many converging lines of evidence that tells me, some people will choose to reject all these lines of evidence, but I believe that they converge on this idea that ApoB is relevant. And the more plaque you have, perhaps the more relevant it is. And I do think it matters. But in the context of all comers, like there are a lot of other things that matter. And is it the only thing that matters? Probably not. Certainly not. Is it the only lever we have? Certainly not. And is it a lever that is actually fairly straightforward to move? Yes. Is it risk-free? It's, I think, an acceptable risk for many people. It is not totally risk-free. Nothing is risk-free. Not treating it is not risk-free. So the question is, what are your true risks? What is your tolerance for accepting the risks of certain kinds of interventions versus others, medications versus lifestyle versus serial imaging versus all kinds of options that we have, right, over time? And again, a lot of those fit, in my opinion, in the spectrum of what is medically reasonable, right? If you were choosing not to lower ApoB, then perhaps we can be choosing to serially monitor. Now, again, I know that the Atias and Daysprings of the world will say, why on earth would you wait until you had a positive calcium score or positive plaque on a CCTA before you would reduce your risk factors? Well, first of all, there are plenty of some people who will still form plaque at low ApoB levels. I have case reports about it. And also, small amounts of plaque are probably not that damning, right? They are a sign that there's something going on we have to fix. But the odds of you having a severe plaque rupture event at very low plaque volumes, but present, are low. So if we detect that early, then maybe we decide, yes, in your case, this is relevant. But if you want to come to me and say, Doc, I have a strong family history. My ApoB is higher than I would like. I have Lp(a). I have X, Y, and Z. I would like to lower my ApoB. No, I don't have a CAC. No, I don't have a CCTA. I don't feel like I need that. I just want to lower my ApoB because this is what I see as an appropriate step in therapy. I am not going to argue about that, right? I will not say that you shouldn't do that. I will also say, what else is going on? Let's check your homocysteine. Let's check your uric acid. Let's make sure your blood pressure is well controlled. Let's make sure you don't have insulin resistance. Let us also take a broad sweeping approach to all of these things. This is a much bigger answer than the question you asked, but I think it's relevant, right? So again, I find myself in this awkward position of being somebody who actively manages lipids in a large number of my patients, and also seeing the other side of this debate to a first approximation, which is that I cannot prove that everybody with elevated ApoB will develop plaque. I just can't. And I can't say that ApoB lowering is entirely benign for everybody. That is also just not true. At which point we say, what do we know about population risks in general? How do we address the individual sitting in front of us? And I have seen it go all kinds of ways, and I can advocate and support people's decision-making in all kinds of ways while still believing that ApoB is relevant. That's kind of where I land on this. Okay. All right, Paul Elkins, the best way to avoid statin side effects is to keep the dosage low. If you need additional ApoB reduction, add ezetimibe instead of increasing the statin dose. Paul, I generally agree with this. I find that most of my patients are able to tolerate low doses quite well. And we get the vast majority of our impact on ApoB lowering at pretty low doses, especially of the two newest agents, rosuvastatin and atorvastatin. And I often will combine it with ezetimibe at baseline. I actually think that combining them, because we're targeting two separate pathways in our cholesterol metabolism, we actually get a lot of synergy, right? Because if all we do is inhibit the synthetic pathway and just upregulate LDL receptors, there's some evidence that we get compensatory reabsorption from the gut, right? The body is trying to be efficient and recycle the cholesterol molecules, and so it will just increase reabsorption. So if we do both, then actually I believe we get often a very synergistic lipid lowering effect, and people can be on kind of low doses of both agents with a nice, very disproportionately high impact. And I still have patients who can't tolerate any dose of any medication, right? I've had people who are ezetimibe intolerant. I have people who are statin intolerant. I have people who are Repatha intolerant. It is not common, but I definitely have people for whom multiple agents, multiple different mechanisms are provoking symptoms in a way that they find intolerable. And again, in 2026, we are fortunate to have a lot of different options, right? We still have inclisiran, we still have bempedoic acid. Soon we'll have LPA specific drugs, I think. And the list goes on. We still have a lot of ways that we can help manage this. We still have a lot of lifestyle interventions, by the way, that we can use to help manage this. We can talk about whether the outcomes would support doing that, but nevertheless, if we're bumping up against a drug intolerance problem, there are still a lot of ways to manage ApoB for patients that really need that to happen. All right, donut time. If you're old enough to take a statin, you already have muscle pain anyway. Don't let that waiting for muscle pain scare you or bias you. So the way that I try to manage statin side effects in my practice is to have a de-escalation, re-escalation, sort of a de-challenge, re-challenge thing. So I will have people stop for a week, make sure their symptoms actually get better, and then restart for a week and make sure symptoms come back. If I see that pattern, then I feel quite confident that it probably is drug related. If that is not the pattern that we see, then we can think about changing dose. We can think about re-challenging again. There are all kinds of ways that you can work with people, but usually the side effects are quick on, quick off. So it's helpful that way to be able to understand what's really happening. And that's usually how I manage that in practice. Lisa, I feel kind of bad when I have to look for another doctor. Yeah, what I can say about this as a clinician is we don't even always notice if you are, like, I don't mean to be callous. I don't mean to say we don't care. We certainly care, but in the kind of day-to-day of a really busy practice, like I will have to go back and think like, oh, was so-and-so patient going to come back and see me like soon-ish? Is it 6 months or is it a year? Like I don't know, maybe they moved away, maybe they didn't come back. Like doctors are always kind of in the moment with the patients that are in front of them. And if you haven't seen them in a little while, they might not even recognize that you haven't come back to see them. They're not necessarily chatting in the like surgeon's lounge or the lunchroom about patients like, oh, Lisa came to see me this week, and like, oh, why did she come to see you? I thought she was my patient. it's just not a thing that happens a lot. And again, your job is to advocate for yourself. Your doctor is also your advocate, I hope, and they should be, but you are your best advocate. And a really good clinician should have enough self-confidence to not be offended or put out if you want a second opinion. Even if I'm sad that like you feel like you have to do it and I'm not good enough for you. That's a me problem. That's not a you problem. And I try to be a big enough person to just recognize that like not everybody's going to be somebody who resonates with me on an interpersonal level, right? We're all our own little special ice cream flavors, and like it doesn't make you a bad person if you don't like butter pecan ice cream. It just means like I'm not the right person for you. I'm not the right doctor for you. It's okay. It is okay to advocate for yourself, find a clinician that you trust and want to work with, because like there is no more important journey than your health right now, right? Like this is the vessel that we have. Your body is the vessel that you have that is carrying you through this short and beautiful life. We have to do our best to take ownership and take care of it because, sad to say, right? I wish that I could tell you that your doctor is the one who's going to care the most about this for you, but they're not. They're not. It's you. So you can feel badly, and I get that. I hear that. I would too, and do what you got to do for you. Termi Cobra, hidden reason that drives up C-reactive protein. Drinking sugar-sweetened beverages like Coca-Cola and even fruit juice. Yeah, so sugar-sweetened beverages, I think no matter what dietary approach you espouse, we could all agree are probably not great for us, and should be a pretty easy, low-hanging fruit to knock out of your nutrition if that's something that you are doing often. Tom, hit like because Lily is the best, and you're getting too old to mean that in a creepy way. I am not creeped out. I appreciate the support. Thank you, Tom Smith. All right. Tommy Surya, what is ectasia of the abdominal aorta? All right, so Tommy, a aneurysm is obviously what we talked about earlier and usually that's defined as twice the normal size. Ectasia is the word that somebody who is trying to say that it's not normal looking, but it's not quite at the level of the aneurysm yet. So it's going to have a shape that bows out a little bit, but it's not big enough that they're ready to call it an aneurysm yet. So ectasia is just an abnormal enlargement, but it's not enlarged enough yet to be called an aneurysm. Do I have, sorry, this is from Dan Galpern. Do I have a dosage or frequency recommendation for lumbrokinase to assist in responding to CVD? I don't at this time. I have not yet really had a lot of experience with lumbrokinase. So you might have seen a video we did recently on nattokinase. That was very controversial. And I followed it up actually with a comment response video where we talked a little bit more about lumbrokinase. I was a little more excited actually about lumbrokinase based on its mechanism and some of the studies that have been done with it. I have not actually quite gone into using it routinely in my clinical practice. So I don't remember in that video if I actually covered what the current dosage recommendations were. We can go back and look for that. But off the top of my head, no, I'm sorry, I don't. It doesn't mean it's not potentially valuable. It just means I don't really have quite as much experience with it yet as I wish I did to help with that. Tom Smith, your daughter had a bit of a tough time in later teens, didn't get scores to pursue becoming a doctor, and somewhat blame high carb diet. Yeah, she is now a nurse. Okay, well, nurses are the lifeblood of medicine, and we would not function without them. I am so thankful that she is chosen to do that, and I hope that that is ultimately a path that is going to bring her a lot of joy and satisfaction. I think you're probably really proud of her, as you should be. Sound mind, should we take nattokinase to lower ApoB? My short answer to this is no. The impact of nattokinase on lipoproteins is actually a little bit variable. There's some dose dependency here. I have not seen a huge impact in my patients who've been on nattokinase in terms of lipid lowering. If nattokinase is helpful, it's probably related to the fibrinogen component or antifibrinolysis. I have not been that impressed with nattokinase, and I am concerned about potential bleeding effects. I was actually speaking to a clinician at a conference recently who has had at least 3 of his patients who've been on oral anticoagulation for atrial fibrillation, who have also been taking nattokinase, have pathologic bleeding events. We talked a little bit about this in the nattokinase video. I don't think it's that there's like mechanistically, it's a very interesting molecule and it might work. And I do think that it might be why, for example, people who have high intake of the natto fermented food may get a lot of benefit and seem to have lower rates of cardiovascular disease than people who don't eat as much of that. Um, I'm just not totally convinced that we have all the science yet on our side to really make it worth the bleeding risk that's associated. When we looked at lumbrokinase, I thought that there was less of a bleeding risk associated with that particular molecule. So if I were going to pick one of these sort of serapeptase molecules or these enzyme-based approaches, I think probably lumbrokinase is where I would be leaning now today with what I know. I know that nattokinase is still super popular in the popular gestalt, but both in my clinical practice, I haven't seen a lot of impact, and I am concerned about the bleeding risk, so I am not currently recommending it. If you are interested in supplements to be lowering ApoB, I think there are a lot of safer, more strongly evidence-based options. So psyllium fiber, right? Soluble fiber is one of the very strong evidence-based options for ApoB lowering. Beta glucan from oats or separately as a supplement is also useful that way. Berberine, dihydroberberine, that is currently what I am experimenting with for myself. That is going to be an interesting video as we wrap that up in a couple of months here to see whether that had much impact, but it has a direct impact on PCSK9 inhibition, so that does have some evidence. Citrus bergamot is another one that could be used for this. Again, I'm not your doctor. I'm just a doctor on television or on YouTube. So you do what you feel with your clinician is worthwhile and best. At donut time, Dr. Lilly, how do you differentiate true neurogenic TOS from arterial compression? What specific criteria do you use to sequence first rib resection versus lysis for Paget-Schroeder syndrome? Okay, we are talking about all of TOS. So thoracic outlet syndrome is what TOS is. There is a space between your collarbone and the first rib that sits right underneath it up here. And it has a bunch of structures that run through it. There is an artery, a vein, and the brachial plexus, which is the sequence of nerves that innervates the whole arm. And there can be compression of this space when people raise their arm. So that is one mechanism by which you might generate untoward pressure on those structures, the artery, the nerve, and the vein. Each of them individually has a separate thoracic outlet syndrome associated with it. Arterial thoracic outlet syndrome is the least common. That is generally related to a cervical rib. So the first rib is a thoracic rib. The ribs are actually associated with the thoracic spine bones, the vertebrae, but you can have the presence of an extra rib that is off of the C7 vertebra, and that's a cervical rib. That tends to cause more compression or an abnormal path of the artery. It tends to cause dilation or aneurysm of the artery where you can get plaque or thrombus clot that forms, goes down, breaks off, and goes into the hand. That's pretty serious, and that typically responds super, super well to surgery. Typically, surgery is removing the first rib, and if the artery is not normal, then you have to reconstruct that artery. If there has been clot that's in the hand, that's a problem. You might have to go deal with that. All issues, but arterial TOS is about 1 to 2% of all thoracic outlet surgery cases that are done and presentations of it. So it's the least common far and away. I haven't treated an arterial TOS patient since my fellowship. The next most common is the venous one, so the vein that runs there. And this can be, if the vein gets pinched enough, it can narrow or even get a big blood clot in it. This is also something called Paget-Schroeder syndrome, right? One of these eponymous things that gets named after smart people who discover these things. Paget-Schroeder syndrome is most commonly seen in people who do a lot of overhead activity. So the textbook example is like a high school or college level baseball pitcher, right? They're doing all this overhead arm movement. Swimmers get it, and volleyball players get it. Lots of people who just spend a lot of time with their arm up over their head, who compress that space often, can get a blood clot there. And management of that is you first treat the blood clot. And so many of us will do something called thrombolysis, which is an effort to go in and dissolve the blood clot, reopen that blood vessel to restore normal blood flow. At that point, then you probably are going to go in and also take out part of the first rib to open up that space so that you don't get another blood clot in the future. We can talk more about that if anybody has experience with venous TOS and wants to know about. There are a couple little nuances there. Nevertheless, the last category is neurogenic TOS. So this is compression of the brachial plexus. And this is a more controversial diagnosis because it's kind of a diagnosis of exclusion. People get pain in their hand or in their arm, and we don't know. Is it from their neck? Is it from their shoulder? Is it from this brachial plexus compression? This is a tough one. And the solution can be surgical, but actually physical therapy is about as effective as surgery in trying to expand and open up that thoracic outlet to allow some of the nerves to decompress. The scalene muscles that actually are running in and around the neck, collarbone, and first rib area can also be implicated. And sometimes doing things like Botox injections of the scalene muscles is enough to relieve neurogenic thoracic outlet syndrome. So the hardest part about neurogenic TOS is making the diagnosis. The second hardest part is trying to evaluate the different treatment options and helping people try to come to a place where like they can regain function and good quality of life without putting them at undue risk. I personally I don't treat neurogenic TOS. I don't even do a lot of rib resections for venous TOS. I will often, I can do the lysis and try to reopen the vein, but honestly, I will usually send that to one of my partners who does a lot of first rib resections just because I think it's a technically semi-demanding operation. There's a lot of high risk real estate in that area, like the brachial plexus, like that whole thing that innervates your whole arm. Patients are young typically, and so this is a big deal. And I personally would want somebody doing mine who did a lot of them. So generally, I will refer my first rib resections to one of my partners who does them. Have I done them? Sure. Could I do one in a pinch? Yes, but I think in my practice right now, that's not something I feel like I'm the best person to do. Okay, keep moving on. Let's see, what do we have here? Great reply about second opinions. SD Johnston, another Johnston. So good to have you in the house. Thank you. All right, George. Australian research covering statin use by over 70s and from memory for primary prevention found a 30% relative risk reduction of MI. But again, no benefit to health span or lifespan. Doesn't make sense. I don't know exactly which paper that is referencing. I know certainly, again, atherosclerosis is a disease that takes decades to form. The plaque rupture event is very quick, but the plaque formation itself is a years-long process. So a lot of our data are shorter-term studies. Oftentimes, we are starting these medications long after the plaque is already present and formed. And so we have to be a little bit careful about understanding, what are we trying to do? Are we totally reducing formation of plaque? Are we trying to stabilize plaque and reduce plaque rupture events? And ultimately, if we're not extending lifespan, but we improve quality of life, I think that's important. And one of the things that I think about a lot when I hear some of these statistics, right? Looking at, big populations, on average, people are going to gain 3 months of life or 3 days of life from statin therapy. Okay, first of all, big populations, right? Some people are going to gain a lot and some people are not going to gain very much. When I make rounds in the hospital every day, I see people who have survived their events, but at great, great cost. So they're in the intensive care unit. They might be on a heart-lung machine to be supporting their organs while their heart is really, really sick. And like we can bring people back from the brink of disaster better now than we could ever before, but it's a lot. And life is never going to look the same for them. So even though, they may not live a shorter life, I think their quality of life, having had this event, is dramatically impacted, right? So if live to 80 regardless, but you had a stroke at 70 and you're disabled for those 10 years, well, do you think that that is interesting, relevant information? Like, did we save your life? No, you survived your stroke, but you might be disabled. You might need skilled nursing care. You might need somebody to help you eat, or, have trouble expressing yourself, or have trouble walking because of that event. So even though there are a lot of people who have a small heart attack and go on to live a totally normal life thereafter, and that's great, there are a lot of people that we are able to come back from the brink and save them despite these events, but their life never looks the same. So their health span, their quality of life is dramatically impacted by having had this event. So I do think that event reduction is actually relevant. And, if you have an event, but then you get a stent, and then you have to be on a year of dual antiplatelet therapy, and then you have a GI bleed, and then you have to go in and get a procedure to deal with that. And then we have to take you off of your dual antiplatelet, and then your stent thrombosis, and then you have to go get another stent. Like, this is what I see day in and day out. And I know it creates a bias for me. It makes me more likely to want to be more aggressive in helping people prevent this disease process. And it makes me think harder about intervening earlier and taking a little bit more risk in the sense of trying to work hard to prevent this disease, because I see how devastating it is. It's a bias, totally. And I do think that when you are just talking about days of life saved, you're overlooking a big component of quality of life potentially. I don't have data that says quality of life changes, right? I really don't have that either. I'm just telling you kind of what my experience is with how this process can look for people in a modern era where we are really good at saving people in crisis, but it doesn't mean that they don't have longstanding issues or impairments from these kinds of events. At Mother Oats, what motivated you to look into non-pharmaceutical stuff like nattokinase? It seems like you go above and beyond as a doctor. I really appreciate you saying that. Thank you, Mother Oats. I looked into it because A, I think it's really interesting. B, there have been a lot of traditional medical approaches, right? Chinese medicine, Ayurvedic medicine, that have been probably pretty successful over thousands of years and know some stuff we don't. All medicine initially started as natural remedies and natural therapies, right? As we have learned and evolved, we've grown to know more and become more specific, but it doesn't mean that we have to throw out everything that ever existed in the past. And probably the most important reason is because patients ask about it, and patients want non-pharmaceutical solutions some of the time. And I don't think I can justifiably only recommend one solution without knowing something about both, right? If I am going to put my foot down and say, I think it's really important that you take this particular medication because it is better in this way, then I have to know what the alternative is. I cannot really make that argument for people without educating myself a little. And I get comments on the channel sometimes like, well, you're a surgeon, you don't know anything about nutrition, you don't know anything about supplements. Guess what? I have a background and a vocabulary that allows me to go educate myself. The only people who get taught about nutrition are dietitians, and their education is very specific. And I would argue that many of them don't know as much about nutrition as the science allows us to be aware of and to know. So guess what? We are all capable of going out and educating ourselves. I would argue that my medical training gives me some more sophisticated biochemistry, some more sophisticated pharmacology to have a deeper understanding of some of these things. Am I professing to be the world's expert? Absolutely not. Do I think you should get a second opinion? Yes, I do. We talked about that too. And I also believe that I have valuable experience and perspective to bring to the scientific literature, right? have a master's in public health. That taught me a lot about how to interpret data, how the studies are written. I'm a published research author. It's not something I do actively right now, but I know how that sausage gets made. That has taught me a lot about how to read it, how to interpret it, and how to bring it into my practice in a way that I think helps me take better care of patients and, again, allow me to answer questions. And all of this is really, at the end of the day, about helping my patients get where they want to go in a way that makes sense for them. And again, I might believe that a pharmaceutical option is more effective, maybe even safer sometimes than a nutraceutical one or a supplement-based option. But it's not my choice to make. It's not my body. And if I'm going to make that recommendation, I want to do it with as much information on all sides of that equation as I can. There are also some things that we just don't have good prescription options for that I think are very impactful, right? Creatine is one we've talked about here recently. I think creatine is very impactful for people, myself included. Like, it's not available as a prescription. So guess what? How do we understand what it's really doing, whether it's helpful, whether it's safe, and what we can expect to achieve, and then how to give it, deliver it, take it in a way that is safe and appropriate? In my opinion, right, frailty is as a big of an issue in end of life optimization, health span optimization as cardiovascular disease. So let's talk about muscle strength and muscle mass, and let's talk about creatine, and let's talk about brain health, and let's talk about all of these things. Because for, yes, as much as cardiovascular disease is the leading cause of death worldwide, right? Number one killer of men and women in the US and around the world. If I only treated that as a vascular surgeon and as a prevention person, I actually do think that that would be helpful for people. But it's not the only thing. And it's certainly not the only thing that impacts quality of life. So, watching my family age, watching my parents age, and my dad have mobility issues, like thinking about, I don't know what's gonna take my dad's life, but at the moment, cardiovascular disease isn't in the running. And there are a lot of things about his health that would be dramatically improved if somebody had sat him down 20 years ago and really had some of these conversations. Now, maybe he wouldn't have listened. He wouldn't have wanted them. But nevertheless, I am struck by how much bigger of an impact I as a doctor can have if I am at least opening the door to have these conversations with people about the other stuff that matters, right? If all I ever do is focus on your ApoB and I ignore the fact that your, BMI is 16 and you are under muscled and you are not doing anything to protect your bones and you fall and break a hip, I mean, I could say that that's somebody else's job to pay attention to, but let's be clear, like, you're in my office and my clinic. I have eyes, right? I can see. Uh, and sure, it is something that's hard sometimes to find time for if you're coming to see me for a surgical problem. But guess what? You can come back. We can talk about it another time. And again, cardiovascular disease is a devastating, devastating illness. And where I have found the most joy and meaning in my practice as a doctor is helping people feel better, right? This is a silent disease, cardiovascular disease, most of the time, right up until it's not. And changing ApoB levels, working on people's blood pressure, on homocysteine, and all of this stuff. Like, labs look better. Everybody feels good and pats themselves on the back when the lab values are all green. That's nice. But they don't always feel any different, right? Normal blood pressure, modestly elevated blood pressure, people feel the same. ApoB of 120, ApoB of 80, people feel the same. What really does help people feel better and come back to me with a big dopey grin on their face is, "Doc, I'm sleeping better. You changed my life with magnesium and my sleep study." Or "I'm working out more now and I've lost the spare tire and I can pick up my grandkids all of a sudden without pain. This has been life changing for me. And I'm getting outside more and seeing the sunshine and I feel so much better." That is what makes my day as a doctor. And to be able to offer that and do that, I had to get out of a pill for every ill. That's not what makes people feel better. So that is kind of part of the story of how I have re-envisioned my career a little bit to try and, very selfishly get more joy and meaning out of my own practice. Tom Smith, I utilize 2 doctors side by side, recognize how many people they have to see with 15-minute appointments. Yeah, going forward, you will book long appointments. I hope that they allow you to do that. Not every practice will allow it. I also try to have longer appointments for patients on the metabolic or prevention side because it just takes longer to go through some of these things. I see them more frequently as well because, again, we can't always get it all done in one visit, or we have to have quick follow-ups to like see if stuff is working or if there's a problem. And so I think all of that is good. If you can get longer appointments, by all means, absolutely. All right. Dr. Lilly, is there a situation, this is from Donut Time, thank you. Is there a situation in which a patient wouldn't benefit from further testing with a CIMT? Maybe someone that's already on medications or had CAC imaging, et cetera, et cetera. So this is an interesting question. I think CIMT does 2 things. The first one that it does really, really well is answer the question, do you have disease or don't you? That question can be answered with other imaging modalities, but as we've talked about, they don't all work the same, right? You could have a CAC of 0 and still have plaque on a CIMT. You could have a CAC of 0 and have soft plaque on a CT angio of your coronary arteries. So a CIMT, in my opinion, as with the cardio risk protocol that also looks for plaque and makes a very concerted effort to incorporate that, is a valuable test to answer the question, do you have disease or don't you? Beyond that, the next piece of this is, does CIMT allow us to monitor effectiveness of treatment or risk reduction over time? I think I'm less confident that the answer to that is yes, but I hope and believe in my heart of hearts that it probably is yes. I just think that the data are a little less strong for it. And I actually got a couple of papers from Dr. Eldridge after our conversation that he sent by email that it's, we're going to work through a deep dive on that and talk about, what we see population versus individual levels and whether, monitoring CIMT as a way to monitor the effectiveness of our treatments is working. If there is nothing else that you can do differently in your life, and getting that information on a CIMT that your IMT is progressing more rapidly than you are aging, right? So your arteries are aging faster than you are chronologically. But if there's nothing you can do about it, then that's not helpful information. What are you going to do differently? You can't. But I find that that's usually not the case. Most people can make some kind of change for the better for their health in their own life. And most clinicians can dig a little deeper and see if there's anything else that we're missing in the risk profile. So I think most of the time there is something that could be done. If you're not willing to do anything differently, then don't waste your money. Don't get the information because you're not going to do anything with it. And if you're working in a system where you don't know who else can help you find stuff to do differently, that may also be a time where it's not really the juice isn't worth the squeeze until you're in a place where you can have a partner who can help you do some of this stuff. But I do think probably for most people, it's again additive imaging to the heart because it's a different vascular bed. And we know that there's good concordance, but not perfect. So you can find disease in one place, but not the other. And second of all, I do think it's a nice way to monitor the health of the arterial system over time. CCTA, which detects soft plaque, and we now have these AI tools that measure how much, what kind have we like stabilized our plaque. Like that's super cool, but it's a decent amount of radiation and contrast dye and cost to be doing it like every year. And every 5 or 6 or 8, or nobody knows, by the way, what the right interval is to re-image somebody with CT angio. We just don't, we don't have a lot of data for that either. So I think for cost and radiation exposure reasons, CIMT is probably how I am going to choose for now to monitor arterial health over time and make sure that I think we're doing an okay job of managing risk for people. But eventually maybe CCTA gets to a point where we can do that more frequently, or we get photon counting CTs that are going to allow us to do it with much less radiation, or maybe we even get, contrast-free protocols and other things where as the technology evolves, this answer will probably change, right? I would not be surprised to look back in 5 years and potentially have a different answer to this question. Okay. Have I seen the research in, so ST Johnston, have I seen the research in Natto that found a significant difference in effects with blood type? Dr. Brewer talked about this recently. I have seen that the video is out there. I'm sure I think it's a single paper, and I have not read it yet. It's on my list, so stay tuned for that. At Vince, finasteride may improve heart function and lower cardiovascular risks by blocking conversion of testosterone into DHT, which drives pathological cardiovascular remodeling. And I lost my place. All right, I'll come back to that question as soon as I get back there. Okay, I'm going to move on to our anonymous questions again for a second here. Thank you for your generosity of time and care. 63-year-old thin female, controlled pre-diabetic, fasting insulin hovers between 4 and 6, healthy low-carb diet, exercises after every meal, very sensitive to medications, IBS, leaky gut. I'm nervous about going on statins because of GI side effects and increased glucose levels because I've managed to keep my A1C between 5.6, 5.8 range for years. LDL has been in the 130 to 155 range for over 20 years. You're an ApoE4 carrier, HDL 78. ApoB is 100, triglycerides are 76. Cholesterol balance is within balanced range, but slightly skewed in the direction of overabsorber. Would Zetia be effective as monotherapy at 5 milligrams to reduce GI side effects? That was one of the things that I was considering. And please share thoughts about pitavastatin, which is a newer medication for the least side effects, minimum dose frequency. So most patients with statin therapy actually don't have GI side effects as the most common thing. I've had one, maybe two patients with very severe GI side effects as the result of statin therapy. It was like an autoimmune colitis type of a picture. Zetia is actually, because it works in the gut, more likely, I think, to have GI side effects than a statin would, truthfully. So either way, I'm not sure there's any good way to know other than to try it and see and hope that it will be something transient, that if it happens to you, you can stop the medication and return to whatever your baseline unfortunate IBS leaky gut situation is, and hopefully not have too much of a flare or a disruption. But honestly, you know, if somebody comes to me with gut issues, like Zetia is my least favorite choice among those, just because it is working in the gut and there is a certain association with GI issues and diarrhea in particular with ezetimibe. Pitavastatin is a less effective statin. That's why it has fewer side effects. So I do think it's worth trying if you are for sure intolerant to low-dose rosuvastatin, but I would probably try low-dose rosuvastatin every other day, even 2.5 milligrams every day or every other day, and see if you can tolerate that. That's, if I have patients who are deeply concerned about statin side effects, that is one way that we can sort of ease our way into that. If that really doesn't work, then sure, pitavastatin is another option that could be trialed, and you could again see whether you're gonna have issues with that or not. I don't know that there's a great way to tell. Statin side effects are usually, they are often agent dependent, meaning just because you have a bad reaction to one of the statin drugs doesn't mean that the others will cause issues. Pitavastatin tends to cause fewer issues, but is also significantly less effective. So it does not qualify even at its highest dose for high intensity statin therapy, which if you don't have active cardiovascular disease is probably not a huge concern. But since you are a relatively thin person, you may get a disproportionate result from Zetia. But again, I would worry about GI side effects in a patient such as with a history that would be similar to yours. Another anonymous question. What's my view on high, small, dense LDL particles on a very low carb diet? All of their markers are fine, like LDL, triglycerides, ApoB, blood sugar, and Lp(a). I do have some plaque. CAC is 110, age 63, taking 5 milligrams Crestor to make my GP happy, but he wants to ramp dosage because of the small, dense particle count. So I think that that's probably still an area of concern. I don't know what your total particle count is. I think there doesn't seem to be a lot of evidence of atherogenic remnants like triglycerides or blood sugar issues, but I would be worried that that small dense LDL might still be causing trouble. So to the extent that your team might be wanting to reduce that even further, I could understand that. If you are not on ezetimibe, I would consider adding ezetimibe potentially before I would increase dosages of statin therapy, just to get that synergistic effect that we mentioned earlier. And I tend to find that that's pretty well tolerated. I don't know whether that has a disproportionate effect on the small dense particles necessarily. We'd have to test. And then the other question would be, are there any dietary modifications within your low carb way of eating that might also reduce the small dense particles even more? Unclear to me, but something you could consider. Okay. I am back on our regular chat here. Yes. Sorry, Vince, I'm finally back on your comment. Finasteride may improve heart function and lower cardiovascular risks by blocking conversion of testosterone into DHT, which drives pathologic cardiac remodeling and hypertrophy. I think this is speaking potentially to the bigger question of, is testosterone and consequently DHT super pathologic for cardiovascular disease? Should we not be doing testosterone replacement therapy for people? And, what is the cardiovascular consequence of that? Traverse trial showed that repleting people to physiologic levels didn't seem to be super risky. No increase in major adverse cardiac events at that level, but there's been a lot of interest in testosterone replacement, both for men and for women. And right now, there were previously black box warnings on testosterone therapy. Those have largely gone away as the result of Traverse. There are all kinds of things, right? Is this the erythrocytosis? Is this a prothrombotic effect? Is this stuff in the liver that's a problem? What are we really considering here? Maybe it is the DHT. I don't know enough about that at the molecular level to give you a great answer yet, but jury's still out and stay tuned for it. Critical thought. Could I share a concise comparison of cardiorisk CIMT versus CRT for detection prevention of CVD, please? Tell me what CRT you're referring to. I'm not sure I know exactly what to do with that just yet. I'm not sure what you mean. Alphin waves, able to lower my LPA from 175 to 118 with diet and supplements. That's awesome. Good job. Paul Elkin. Yes, thank you. Tom Smith, improving quality of life. We've been using nitroglycerin since 1879 to relieve the pain of angina. Yep. Donut time. I'm sorry you always overeat when you watch my videos. I don't know why that happens to you, but all I can say is put some nice healthful snacks and some like extra fizzy water in front of you first and see if that helps. Maybe retired. Thank you. I appreciate you. Monterey Fog. I'm good at this format. You're enjoying as a first timer. Thank you for joining Monterey Fog. We're really happy to have you here. Let us know if you have any questions. James, thank you so much. Really appreciate you and your support here. Getting Alphin waves, getting insulin optimal under 5, blood glucose monitor. Yes, I actually am a big fan of the blood glucose monitor for educational purposes for people and having them learn what might cause glucose excursions. I think not everybody responds the same way to foods. I have some people who can eat oats, for example, and have a totally stable normal blood sugar, and another person who eats the same exact meal who gets a blood glucose spike. I know some people don't think that spike is always relevant if you come back down in a timely fashion. That's maybe a longer conversation for another day, but it is relevant. Paul Elkins, ezetimibe does cause GI side effects. However, there was a study that showed a half dose reduced ApoB at the same amount as full dose with much less side effects. Yeah, so this is the question of whether 5 milligrams of ezetimibe would be as effective as 10 milligrams. I think that's an interesting thing. At Shimon, my C-reactive protein was 5.5 and you were placed on statins, experienced pain and ditched pills, plus eliminated sugar and level lowered to 4.3. That's awesome. I would love to see that hopefully come down even further for you, right? Under 3 would be great. Like 1 to 3 is average risk. Under 1 is improved risk. So hopefully all of those good lifestyle changes will help keep that going in the right direction for you. Critical thought, CT scan testing. Okay, good. So CIMT versus a CT scan. The CT scan most people are talking about now is going to be the CCTA, right? CT coronary angiography. This is a contrast-based CT scan of the coronary arteries where we use dye to be able to visualize the flow channel so we can see calcified plaque, but we can also see soft plaque and how much narrowing there might be in the artery itself. The step back from a CCTA would be a coronary calcium score. That is far and away the most common screening tool that's being done today. All it does is look for calcification, but it doesn't actually show us how much narrowing, if any, there is, and it doesn't show us how much other plaque there might be. And again, there's been some conversation today about whether, the hard plaque is benign or not, whether it's really the soft plaque. I do think soft plaque is relevant based on my read of the literature. I'll go check out that other video and we'll see more about that. But the current best guess I have is that soft plaque is relevant. So getting that imaging to show whether there's a lot of that or whether all of the plaque that you've had has been stabilized over time, I think that's relevant. But CAC, coronary calcification, is the easier test to get, at least at a baseline, and more accessible. So, the CT scans right now are mostly showing the coronary circulation around the heart. An ultrasound-based test is going to be looking at the femoral vessels in the leg, or more commonly, the carotids in the neck. The carotid is what I image most of the time, but actually there's some reason to believe that imaging the femorals in addition would also be helpful and provide some additional information to those scans. Again, we know disease shows up in different vascular beds at different times and in different people, so they're complementary. I'm never going to say that one test is the test to rule all. They all have advantages. They all have drawbacks. I think I've said this before in the channel. Generally speaking, in the all comers, coronary calcium scoring is probably the best place to start because it's the easiest to get, it's the cheapest, it's the most reliable at a kind of a reproducibility, reliability standpoint. And if it's wildly positive, then maybe going ahead and getting a CT angio is worthwhile. If it's negative and you're high risk, you might still choose to do that for more information, but at least you would feel confident that your immediate risk is lower. Or at that point, getting a CIMT, if you can find a high quality test like a cardio risk CIMT with a very rigorous protocol and plaque detection to go looking to see whether you might have disease in the carotid circulation. It really depends on what's available to you, how old you are, right? The younger you are, the less useful coronary calcium screening would be. And all of that is going to impact, where you are in the world, what's available to you, what your budget is, what, if you need insurance to try to cover it, how that's all going to go. These are interesting and difficult choices. But again, CT always has radiation involved. Ultrasound is nice in that there is no radiation. So at least it's got that going for us. All right. Barbara asks, okay to eat Faroe Islands salmon, 16-20 ounces per week to get omega-6 to omega-3 ratio better. I only eat raw organic nuts and nut butter on low-carb diet, but it's apparently driving up the omega-6. Yeah, I think fatty fish is a great way to improve your omega-3 to 6 index. Absolutely, by all means. Easy and cheap to get CIMT and CAC, but hard to get the CT angio. Yeah, I mean, it's very cost prohibitive right now. And again, I have some issues with potential quality, reliability, reproducibility of the overlying or the AI overlays. We've talked about that as well. Just a long road. I think eventually costs and radiation will come down. The AI overlay tools will probably get better and better over time. Our ability to interpret and use them appropriately will get better over time, but it's still pretty early days with all of that. All right. Another anonymous question. When one has zero calcified plaque but a buildup of soft plaque, can soft plaque actually be reversed? Not stabilized by a calcification, but reversed. The answer is sorta. The plaque reversal, right? We've talked about plaque regression. People mention this. It almost never goes away completely. It can get smaller, whether that is actually delipidation, meaning taking some of the fatty molecules out of the plaque itself, or whether it's reducing the size because we're reducing the inflammation component of the plaque is a little unclear. But if you look at the studies where they're describing plaque regression, they're talking about it in fractions of a drop of water, right? A drop of water is about 50 cubic millimeters. And when we're talking about what we see in like the most sensitive plaque regression studies, people are talking about, 4 cubic millimeters of plaque regression in an overall burden of, 100 to 300 cubic millimeters of plaque. So like it's tiny, it's a tiny percent, and it's a tiny overall volume. When we think about plaque reversal, it's not like you get this factory reset where your arteries just completely go back to normal. I think it's very possible that you get a lot of regression, and maybe some of it's actually clot and not plaque. If that's the case, then maybe it does go away more completely. I have heard stories of people saying they entirely reversed it and it went away completely. I have not personally, I don't think, seen that in practice, but I don't dispute it's occasionally possible. It's certainly not what we are seeing at the research level in, hundreds of patients or thousands of patients as we're describing plaque regression. That is very, very small volumes. Most of the plaque will still be there. And overall, the goal should be stabilization and to think about it from that perspective. Is calcium required for soft plaque to transition to hard plaque? In a state of high vitamin K2 and LDL below 50, will soft plaque regress without calcium? And I assume that we don't know yet, but a number of people are taking high amounts of K2, MK7 with enough statin levels to regress plaque. What will the outcomes be? So calcium is technically required to generate the calcified hard plaque, but I do think there is probably a plaque stabilization um, spectrum that does not have to use calcium. So partly you can stabilize plaque by increasing the thickness of the fibrous cap. The fibrous cap is not necessarily calcified. That can be more soft tissue. It's much harder to assess. Like we can't really tell as well yet with some of the CT technology. We need more invasive tools to measure that fibrous cap. So like I can't tell you based on a Clearly or a heart flow study how thick the fibrous cap is. Like you need intravascular ultrasound or computed OCT technology to really like understand that. But I think it's possible. We don't have as many good ways to assess whether that's what's happening at the level of most people who are getting these imaging studies. I've had a CCTA with contrast and plaque analysis by heart flow. However, no access was given to me or my cardiologist to the heart flow analysis and visualizations I see on social media. Is this typical? What's the right way for patients to get access to that? That's a great question. And I have not had as much experience with the heart flow scans as to have a good answer for you. I can understand maybe not providing it to the patient directly, but your cardiologist should be able to get it. So if it were me, I would sort of recommend asking your cardiologist to reach out to their heart flow representative and seeing how they can get more information from that. And that's probably the next step I would take, because I'm not sure if your cardiologist who ordered the study doesn't have it. I don't know who does. So somebody should have it. And I hope that you can get that made available to you. Another anonymous comment. Dear Lily, so tests like CIMT or CCTA, screening tests for atheroma in asymptomatics, need to be subjected to randomized trials to evaluate if they have utility and their use leads to clinical benefit or not. Yes, we did this for mammography screening, and the test was dramatically worse than protagonists found in uncontrolled trials. So now that we know the number needed to screen to prevent one death is 746 women. Yeah. Without this critical data, it's hard to ethically consent patients to these unvalidated tests because the risk-benefit ratio is unknown. And of course, insurance companies need to know about the cost effectiveness. My guess is the number needed to screen is greater than 5,000. We need to stop doing ad hoc screening and limit these tests to evaluation in ethically approved clinical trials. I agree that we should have more data, and I do agree that clinical testing is going to be helpful. I am not certain that I think it's unethical to do it until then. I don't know that it's any more ethical to be offering people a bunch of sort of risk mitigation strategies without having any way to follow them. And, like we talk sometimes here about like whether screening is effective and like what is necessary. There are a lot of things that I think I do as a prevention person that are not necessarily, that are above and beyond what's guideline directed. And what we have from our, like, the problem with this is going to be that the clinical strategies are going to be hugely impactful above and beyond the screening strategies. So you're actually testing two different things. You're testing the ability to detect the disease and then the ability of us as modern medicine to impact the disease going forward. And that's going to take, again, decades. These are going to be very, very expensive trials. And those of us with broad perspective on cardiovascular disease risk believe that many things are required to reduce the risk of events, including optimal nutrition and movement and screening for disordered sleep and management of atherogenic dyslipidemia and inflammation and visceral adiposity and insulin resistance, right? All of these things are important. There are a few trials, right? Like Dean Ornish's whole cohort of like people who did all of the different things. They had a mindfulness practice and they did their nutritional strategy and they did exercise and they did other things. Like I forget what the entire slew of interventions was, but they did show that it was possible to regress plaque. And again, it was too short to have outcomes data. But if what you're looking for is a trial that's going to say we do CIMT at age 40, we do a like multifaceted lifestyle and medication when indicated approach for cardiovascular prevention over the next 15 to 20 years, and then we have outcomes-based trial data to show that this is impactful, I think that's a big lift. It's going to be a while before we get there. Meanwhile, we still have cardiovascular disease as the leading cause of death in men and women around the world. We got to do something differently, in my opinion. I don't think what we're doing is adequate. I don't think waiting until people have these events is adequate. So do I believe that there's a possibility that we're overtreating? Sure. I have to acknowledge that, right? That is the scientist in me that says we don't have the randomized data yet. I also believe that I'm doing something differently that is above and beyond what's currently recommended by guidelines, but I've been an author on guidelines. I know how far they lag behind our current evidence base, and it's at least 5 to 10 years. So I think that there's a middle ground here somewhere, which has to do with informed consent, and it has to do with trying to give people a pathway that makes sense for them when they want to know, and acknowledging that our knowledge is very imperfect. And, we might be overtreating and we might be over-detecting. But again, we've not really moved the needle as much as we wish we had on cardiovascular disease. So maybe it's time to do something differently and hope that it works and acknowledge that it might not. And again, I hear what you're saying, and I don't entirely disagree with you that it's important to do the studies and the trials. But having as much experience as I have in the science side of it, I'm concerned that the trials are not going to adequately show me what is happening in my practice. They are going to be a poor facsimile of what I am doing. And again, it is hubris. I acknowledge it's hubris to think that I am better and I am doing something that is above and beyond, and surely what I am doing is helpful. I get it. But I feel like the consequences of this disease are bad enough and our current strategies are not working well enough that I am offering something that is above and beyond. And you're right, it's not entirely supported by the evidence, but some of the evidence is just never going to get there in time for me to help. All right, what do we know about elevated homocysteine levels? We know that they are absolutely associated with increased risks of both stroke and heart attack. Reducing them with intervention may help with reduction in certainly stroke risk. That was actually shown in the Cochrane analysis. They didn't show an improvement in MI, but I also believe that they used the wrong intervention to lower homocysteine and had some problems with chronic kidney disease patients, and that probably confounded the results. So I think that lowering homocysteine is advantageous and very low risk. So I like to do it. If you want a deeper dive on that, let me know in the comments below. All right. Just had a mini neck lift and partial facelift. What are good supplements and peptides to fight off inflammation? So you have just had induced trauma and you need some inflammation to heal. Inflammation is a natural part of your body's healing response, and it is absolutely necessary for good wound healing to have some inflammation. Hopefully, it will not be chronic, but I would just recommend whatever your surgeon has advised in terms of ice packs, maybe some non-steroidal anti-inflammatories to help your healing process not be extended too long and to improve your comfort. But your goal should not be to completely suppress inflammation and the healing response. All right. 46-year-old isolated calcified calcium score 57 in the LAD, but no soft plaque on CCTA, metabolically healthy, slightly elevated Lp(a), which has been lowered through lifestyle, history of smoking, and parotiditis. Calcified plaque seems to be oldish, right? No soft plaque. Is this correct? Is monitoring in 3 years with CTA a reasonable option, or should you already consider pharmacotherapy? 46 years old with calcified plaque in the LAD. If there's no soft plaque on a CCTA, that's somewhat reassuring. I agree. Again, my question to you is the same as the question I had earlier, which is how was that determined? Was that a radiologist read, or was that a more comprehensive quantitative AI overlay? Because my confidence in the radiologist's ability to detect early amounts of soft plaque is actually kind of low. So I would just potentially, if you were on the fence about pharmacotherapy, consider maybe taking the added cost and expense of getting the AI overlay just to see if there is more plaque there than maybe the radiologist was able to detect. Next question. What's my take on Malcolm Kendrick's "The Clot Thickens," that atherosclerosis is a process of repeated thrombosis and healing rather than LDL-driven plaque accumulation being the primary cause? I have read that book, and I really enjoy Dr. Kendrick's humor and writing style. I am intrigued by the hypothesis. I think he presents some interesting supporting evidence, but I am not convinced that it negates the impact of atherogenic ApoB particles entirely. And I also think, again, as I mentioned earlier in the AMA, I have some concerns about the number of people we have on antiplatelet and anticoagulant drugs who still have events. And again, maybe it's just not long enough, right? If this microthrombotic process is happening over these decades, again, it's the same argument that I just made earlier with lipid lowering therapy. If you're starting really late, maybe that's not adequate. And we just need to be more aggressive earlier in life. But again, bleeding risk with these agents is super high. And I don't know. Again, the question is, if that's true, what's the approach to treating it, managing it, and helping people not develop the consequences of this? Because again, we have patients who are on aspirin and Plavix and still have events. And maybe the answer is it's just too late. But is the bleeding risk the way to solve this? We don't know. We have to figure out how to do a little better than putting everybody on blood thinners from age 30 onward. All right. Tahoe style tirzepatide seems to be showing some degree of improvement in the cardiovascular system. I started Zepbound 8 weeks ago and have already lowered blood pressure. Yes, awesome. Good job, Tahoe. I think tirzepatide is probably going to have an indication for cardiovascular disease prevention soon, like Ozempic or semaglutide does. We haven't seen it out in the trials yet, but I am cautiously optimistic that we are going to see the same reduction in cardiac events in the trial data as we are also observing in the cohort studies and retrospective cohorts. I am pretty enthusiastic about these drugs when used safely and appropriately in the right patient population, but particularly if you have excess visceral inflammation or inflammation from visceral fat, they can be hugely helpful. If you have recalcitrant insulin resistance, I think they can be very helpful, and I am excited about them for the right patient when used appropriately with resistance training, adequate protein, good monitoring of muscle mass, bone health, and all of those things. All right, guys, I have one more anonymous question. I have been classed category 1 for an angiogram. I was told I would either have 2 stents if they can be placed. If not, I will need a bypass. This was around 6 months ago. Should I have this procedure or should I keep going with my life changes? I don't have any symptoms with blocked arteries. No info was given to me other than you're going to get this procedure. I'm not sure where you are because I don't know what class 1 means. And I don't know how they have made that decision. So what I'll say about cardiac stents, again, not a cardiologist, don't play one on television. I don't put in cardiac stents. I only stent the arteries in the arms and legs and kidneys and intestines and neck and everywhere else. Stents for coronary disease are helpful under some conditions and actually not so helpful under others. I will go back to my earlier statement. I think a second opinion is always worthwhile, and ask them to explain, right? Ask them what is the consequence to not having the procedure, what is the risks and benefits of the procedure, and, would they recommend this, would this physician recommend it to their sister or brother if it were them, and why, right? What are they afraid of will happen if they don't do it? And get that other opinion so that you can make a better decision, because I don't know that it's the wrong one. I just don't have, and you don't have enough information to feel confident about that choice. And I think that's the bare minimum that I would want for you before going through all of that. Donut, I have a feeling these peptides are going to start be putting in chips and donuts and Snickers. Yes. I hope not. I hope not. You guys have been amazing. Thank you so much for all of your great questions, for the awesome discussion. I have had such a great time. Until next time, take really good care.